in the morning case as well, we had a discussion whether to predilate or not, and there were two different views. So this is an ongoing debate. I don't have any financial relationship. So let's look at, why, the TAVR, which is, the emphasis has been on the simplification of the procedure these days, and balloon predilatation was initially considered a mandatory step to cross and prepare the stenotic valve. But several studies demonstrated the feasibility of performing TAVR without predilatation, and balloon postdilatation is sometimes required, we saw, to optimize the results. But the contemporary consensus advocates an individualized approach, therefore pre and postdilatation are performed selectively. So let's look at the advantages of predilatation, why we have been doing it, because the mechanical effects of BAV are fracturing of calcium, separation of fused cusps, it increases the orifice area to allow smoother passage of the TAVR valve, and ensure uniform expansion of the prosthesis by decreasing the radial counterforces. Avoids PVL or valve malposition for self-expanding TAVR valves because they often have a lower radial force. But the pre-BAV has also been associated, and it has been related with increased procedure time, hemodynamic compromise, AKI, increased conduction disturbances, and increased stroke risk. So the question is it really needed? And what does the evidence says? And we have registries and meta-analysis which have suggested that pre-BAV could perhaps be omitted, or it can be limited to certain selected patients. I think the master is here. You gave the first evidence where the 60 patients were studied with the SEV Medtronic valve, and it was considered feasible and safe, resulting in similar accuracy, acute safety and efficacy as the standard approach of TAVR with predilation. Now, these are certain randomized control trial. They are the largest one, 2019 and 20. The direct travel was with the self-expanding Evolute R generation, and devices success was found to be similar in both the groups. The direct TAVI, RCT, it was with the balloon expandable Edward Sapien, and device success was again similar. So these are certain studies which I just went through, and this was the impact of predilation during transcatheter AVR, insight from the Partner 3 trial. And the conclusion was that the direct transcatheter aortic valve replacement is safe, can be used carefully in selected patients with low risk anatomy, and predilatation may be used if necessary with no significant increased risk in complications. So these are various evidences. This is the 2022 meta-analysis of all these studies, where the author studied the 15 studies. 12 were observational, 3 were randomized controlled trials, and they were completely matched, the overall population, BAV, pre-TAVI, and direct TAVI. And again, the conclusion of this meta-analysis was that direct TAVI is feasible and appears safe compared to predilatation with BAV. A direct approach is associated with comparable device success and performance, and direct implantation might be a reasonable first choice approach with new generation valves leaving BAV predilation for selected cases. So all studies, I think, prove the non-inferiority of direct TAVR concept, which has been widely adopted in daily routine of the clinic so far. So let's look at the pros and cons. Now, if we look at only the predilatation part, the advantages are uniform prosthesis expansion, reduced PVL, and reduced need for balloon post-dilatation, but at the expense of hemodynamic instability, longer procedure time, requirement for rapid pacing, acute kidney injury, and conduction disturbances. Now, these are certain points, disadvantages or the cons of predilatation, but each of these points has controversy in its own. The hemodynamic instability can occur because of the rapid pacing, and severe AR can lead to hemodynamic instability. While this transapical registry showed lower requirement for catecholamine use with direct TAVR, but there were greater troponin release have been noted with predilatation and rapid pacing, suggesting myocardial damage. So these are the thoughts about the hemodynamic instability which can happen with the predilatation. So the idea is whether we can really avoid in patients who really don't need it. But there is a contrasting viewpoint. The same findings were not replicated in the TF registry, and the Brazilian TAVR registry by Bernardi et al. Reported that hemodynamic instability related to valve positioning in those patients undergoing direct TAVR implantation in about 2.8% of cases. So the time taken in a non-predilated valve produce more hemodynamic instability. So this is a contrasting viewpoint. Now, if you look at the conduction disturbances, there is a two-hit model which was proposed by Lang et al. The first hit is during the BAV, resulting in the inflammation, intramural hematoma, with the second hit being valve implantation. However, smaller balloon size and moderate predilatation approach, which is used, mitigates this risk of increased conduction disturbances. So this is one viewpoint. And again, there is a contrasting viewpoint that some of the meta-analysis and registries have reported either decreased PPM rates or neutral effect of BAV on pacemaker rates if there is a pre-BAV which is done. And the direct TAVI and the direct trial both had, they did not had increased PPM rates in the pre-BAV arm. So again, this is a little too contrasting viewpoint. Acute kidney injury has been reported, but I think it's all depends upon how much contrast we are using at that time. Again, about the stroke, pre-BAV can result in valve debris embolization resulting in stroke, but there is a contrasting viewpoint that which showed that the studies have shown that the transcranial Doppler during TAVR, device positioning and balloon post dilatation may be a more important predictor of cerebral embolization of particulate matter and not the pre-BAV. And the balloon post dilatation has been associated with higher rates of clinically evident cerebrovascular events. These are the contrasting viewpoint. So avoiding pre-dilatation to reduce the potential risk of cerebral embolization during BAV may not be justified if the balloon post-dilatation rate increases in a direct TAVR approach, which has been seen in a number of studies, including the direct trial. Again, two contrasting viewpoint about the paravalvular leak and requirement for post-dilatation, conflicting evidences in the studies. Some studies have shown that direct implantation avoids disruption of the valvular calcium and allows the valve to sit more securely, thereby avoiding PVL. While the other studies, they have suggested that pre-BAV avoids non-circular valve expansion under expansion, which will reduce the PVL and the higher gradients, which is related to under expansion. So again, two contrasting viewpoint about these. So with so many contrasting views, what should we do? We can choose pre-BAV based on certain criterias, which are the clinical assessment of the patient, anatomical consideration, and the planned valve choice, the prosthesis which we want to choose. So, we can avoid pre-dilatation. These are the points which we can look, which we usually look in our patients. A patient who is vulnerable to the effects of hypertension, such as reduced ejection fraction or RV function, severe CKD, rescue TAVR, which patient is already hemodynamically compromised. Then there are anatomical consideration. I think Sushil discussed few points about how to read the CT analysis. So there are echocardiographic criteria, varies critical AS, irregular valve orifice, presence of calcium nodule. Again, CT criteria of heavily calcified valves, horizontal aortic root and excessive tortuosity. And these are unfavorable for direct TAVR, and I think BAV is something which we should look at. Again, looking at the prosthesis choice, BEV, less chances of under expansion. There's a possibility of going with direct TAVR. SCVs are known to have lower radial force and maybe under expanded or obtain a more eccentric geometry after deployment. So we should keep a low threshold for pre-VAV. Core valve family may be implanted without the use of pre-dilatation due to better radial force. However, valves like the Navitor, Accurate Neo devices, they are almost always deployed after pre-dilatation at most of the centers. So this is the summary of what I have been discussing. I think we have to look at I think Dr. Rath sir discussed about the in the coronary assessment. So if we have decided for valve sizing in patients where we are doubtful and or the assessment of coronary occlusion, we have to consider the behavior in these cases, which are not that common with a good CT analysis. We are always able to make the judgment beforehand. While looking at the clinical risk which we discussed, if they are all present, we can consider the direct TAVR. Unfavorable anatomy, we need to consider the BAVs, and again based on the valve choice. So I'll just put up some case scenarios. I think this kind of calcium with a critical AS, I think pre-BAV becomes very, very important, because these are the patients where navigating and crossing the valve is going to be difficult, proper expansion is going to be difficult. So these are the patients where we will have to predilate. Similarly, this is a case now with hardly any calcium, but bicuspid type 0. So what should be done? Should we predilate these kind of cases, or should we go directly because there is hardly any calcium? So this is one thing which I would like the expert panel to discuss. So this is the case which I did, and hardly any calcium but a bicuspid aortic valve. But I found I thought I could get away without predilating. It was very difficult to cross the valve, and I had to predilate this valve. So I think this K formula to decide predilate or not, the clinical status of the patient, anatomical information from echo and CT, prosthesis choice, BEV versus SEV, and the type of SEV. And I think the most important is the experience of the operator, because that will all combine, all the three things can be combined only by an experienced operator to decide whether this patient will need a predilatation or not. Thank you very much, and I think we are okay.